Good evening, welcome to the Pediatric Voice, and thank you for watching Bethany TV Uganda. I'm your host, Dr. Helen Namsoke. Well, we are just a few days to the World Hearing Day. That is the 3rd of March 2024, and the theme for this year, they are creating awareness to hearing difficulties in the different age groups and avoiding stigma to those that have different hearing difficulties. But first, do children as well suffer hearing difficulties? Well, the celebrations this year for Uganda will happen in Gulu. That is organized by the Ugandan Otolaryngology Association, that is the ENT doctors of this nation and ENT clinicians, that includes the nurses, the clinical officers, and so many of them. But before we celebrate, we want to as well create awareness about hearing difficulties in children. Now, hearing difficulties may range from total hearing disability to mild hearing difficulties, and this may affect speech and so development and so much more in a child. So today we are hosting one of the ENTs in this nation, that is Dr. Masiko Cedric, who is an ENT at the Chibuli Muslim Hospital. He trained in Makerere University, both for undergraduate and postgraduate studies, and he's very passionate about the diseases of the ear, nose, and the throat, especially the diseases of the nose. He has a very interesting product that helps children that have nasal congestion. But today he's here to tell us much more about hearing loss and hearing difficulties amongst children. But first, before we delve deep into the discussion, let's first have a documentary on hearing difficulties in children.
Hearing loss can affect a child's ability to develop speech, language, and social skills. The earlier children with hearing loss start getting services, the more likely they are to reach their full potential. A hearing loss can happen when any part of the ear is not working the usual way. This includes the outer ear, middle ear, inner ear, hearing nerve, and the auditory system. About 25 per 1,000 children suffer progressive hearing loss, according to World Health Organization. The signs and symptoms of hearing loss are different for each child. If you think your child might have hearing loss, ask the child's doctor for hearing screening as soon as possible. Don't wait. All babies should have a hearing screening not later than their 3rd month of age, or at least before they start school. Early diagnosis and treatment is very important.
Dr. Masiko, welcome to the Pediatric Voice and Bethany TV.
Thank you. Good evening.
Our viewers out there would like to know you a little more.
Good evening, and thank you, Dr. Helen, for hosting me on the Pediatric Voice. I'm glad to be part of the show today. Okay. In preparation for the World Hearing Day. Thank you very much.
Welcome. So you've seen that documentary. There are about 2 to 5 per 1,000 children that are born have a bit of difficulties in hearing. Some are mild, some are in severe form. In other words, they can't pick anything through their ears. But first, we want to know what are hearing difficulties.
So, hearing loss is a broad term that typically represents the loss of the ability to transduce auditory stimuli, which an auditory stimulus is it could be a call from your mother.
Just break it down. What are auditory stimulus?
So an auditory stimulus.
Yes.
So hearing loss is the partial or complete loss of the ability to transduce an auditory stimulus into information that is fed into the brain.
So what I've been told,
so an auditory stimulus would be our conversation we are having right now,
okay,
or sounds made by a chirping bird,
or any sound in other words,
or any energy in form of sound,
okay,
is the stimulus.
Okay.
So that stimulus has to come to the ear,
okay,
which is, to give context, divided into 3 parts. That is the outer ear, the middle ear, and the inner ear. Our viewers who are doing homework for science for their primary 6, primary 7 children must be well versed with this science, because it's at that age when they teach this science, and the children know it so well. So you have to get the stimulus.
So any noise from somewhere, okay, then it comes to the ear, and then what happens?
So the ear is, like we say, divided into, has 3 parts. That is the outer ear, the middle ear, and the inner ear. What the outer and middle ear does is to transmit that sound, amplify it, and present it to the inner ear. So
wait, I want to understand this. So the outer ear picks the sound.
Correct.
The noise from wherever it is coming from.
Yeah, noise is
okay, the sound.
The sound, yes.
Okay, and then it moves it.
So it moves it up to the eardrum.
Okay.
Where it gets amplified. So it hits the eardrum, gets amplified by the coupling system that is made up of the ossicles that cause a vibration and deliver that sound.
So in the middle ear, the sound is delivered.
And it is amplified by a certain value.
Okay.
And it is taken into the inner ear at the oval window.
Okay.
So it's in the inner ear where we have movement of the sound wave in the fluid within the cochlea, which has hair cells that transduce this sound energy into an impulse or electricity that is delivered through the cochlear nerve or the hearing nerve to the brain stem. Then it goes to the brain or the auditory cortex that receives the sound and transduces it to make sense of the information that has been delivered.
Okay, in simple terms, dear viewers, we will have 3 parts of the ear. That is the outer ear, the middle ear, and the inner ear. So the outer ear is the one that picks the sound from wherever it is coming from. Then the middle ear is the one that transports and increases the volume or reduces the volume. In other words, amplifies the sound. And then this sound is later moved to what we call the inner ear, which you don't see at all. And then this inner ear makes sense, a bit of sense of the sound, right, doctor? And then it is that sensible sound is moved to the brain through a certain nerve, and then you start making sense of this sound. Not so? Very good. So what is hearing loss? So
when we look at hearing loss, what normally is out there is they'll say someone is deaf, but deafness is part of the part of the hearing loss. And to start with deafness, we say that someone is deaf if they have a profound hearing loss.
In other words, they cannot pick
any sound, irrespective of the amount of amplification or however loud you raise your voice. So like we said in our definition, hearing loss is either partial or complete loss of your ability to transduce a stimulus and make sense out of it.
So there is a sound somewhere that is being made by someone or something, but for you, you cannot pick it or you cannot make sense of it. And so this can be either complete or partial.
So in managing or in explaining hearing loss, we categorize it. There are different categorizing systems, but the most popular one is the World Health Organization classification of hearing loss, that you'll remember there is a unit called a decibel that is used to quantify the amount of sound that is produced.
Okay.
So from classification, we have mild hearing loss, which is from 0 to 25 decibels. Sorry, that is normal hearing, from 0 to 25 decibels. So someone with that in hearing in that range after measurement will be classified to have normal hearing. However, between 26 to 40, that is mild hearing loss. Then from 40 to 60 decibels, that is moderate. Then we have 61 to 80 severe, 61 to 90 severe, then greater than 90 is profound hearing loss, or what you'd call deafness. So any hearing loss that is greater than 40 decibels would be classified as disabling hearing loss, because at less than 40 decibels, yes, you have a loss, but you cannot face difficulty in conducting
your daily
activities, your day-to-day conversations. And the reason behind this is the energy produced by a normal conversational voice goes up to about 60 decibels.
Okay.
So
like how I'm talking to you now.
So if we had a machine that measures the decibels, would be somewhere in the range of 60 at conversational level. So mild hearing loss will almost always exclusively go unnoticed unless the caretaker, the patient, the parent is very keen. So that is why we say after 40 it becomes disabling hearing loss, because it is at that point when they start to get difficulty.
When someone starts pardoning everything.
Pardon me, or if they have trouble listening to conversation against the noisy background.
Okay.
Or if they have trouble listening to volumes that are low, and they'll have to probably increase the volume on their TV set. So that is the objective way in which the hearing loss is classified, and this is also used to inform the different treatment options that we provide for people with hearing loss.
Okay, that is very interesting. So having seen, do children suffer hearing loss? Usually here the elderly, they are more known to pardon, to ask for pardoning, you know. Do children as well suffer hearing loss?
Definitely. So hearing loss in children, or pediatric hearing loss, is a broad subject, and it is very common, and it is very crucial, because it is at this age in children where you need to hear for you to learn something. So speech and language acquisition is very important and happens in the first years of life.
Because you cannot speak what you've not heard.
For example, if you've never seen or heard about Bethany TV, you'd not say the word
about
Bethany.
it. Yes. Okay. So in other words, if a child has difficulties in hearing, they are as well going to have difficulties in speaking.
Correct.
Very good. So what really causes hearing loss in children?
So for us to talk about hearing loss in children, it would be safe or easier to guide the discussion by looking at by first categorizing the different forms of hearing loss.
Okay.
So hearing loss in children is mainly classified into two categories. It could either be congenital, that is it's
inborn.
Present at birth, or you're born with it. Or it could be acquired. Generally, by the rule of thumb, most of the things that are acquired are commonly reversible, I'd say, whereas those that are congenital
are hard to reverse.
Are more likely not hard to reverse because there is treatment that reverses it, but would be permanent without some form of rehabilitation.
Okay.
So, congenital hearing loss that's present at birth, like you said earlier on, is known to affect about 1 to 3 children.
So it is actually more common among the children.
1 to 3 children in the newborn, 1 to 3 children out of 1,000 live births. That is the rate at birth.
It is that common. Just know for every 1,000 babies that are born,
There is
3.
There is 1.
Let's go to the maximum. 3 of them have issues. Okay.
Then as the children grow older, or when they get to the school-going age, the rate even becomes higher. That is, it goes to about 4 to 6 per 1,000, because the other causes of hearing loss become more common as the children,
as they are growing.
So when we look at the ones that are present at birth, that is the congenital type, that can further be divided into genetic and non-genetic. So the genetic hearing loss is the most common, and it accounts for greater than 50% of that number. And it's either autosomal dominant, sex-linked, or autosomal recessive. So it depends on the way the genes mix, and really it happens, it is chance.
Okay. Dear viewers, like we've already said on this show, genetics, we mean the blueprint. For those of you who know civil works, constructions, the blueprint is the one they follow to come up with a building. It is the mapping of how the building will come up. So even a human being has a mapping of themselves, and that is the gene. The way it came out, the way you were mapped, should I say by God, is how you will come out. So if your mapping for hearing goes wrong, then you'll have difficulties in hearing.
So thank you very much for making it quite easier. So for the ones that affect the blueprint or the mapping, some of them are syndromic and some are non-syndromic. But the biggest percentage of that group will be non-syndromic. It will be an otherwise normal child without any other abnormalities, but they'll have hearing loss.
So syndromic actually means, remember earlier on we had a discussion on birth defects in children, and we said if someone has more than one birth defect, usually there is a way we group the several birth defects and come up with a known syndrome. We call it a syndrome. But if you have just one birth defect, then we cannot call it a syndrome. So
in the non-genetic, they'll have no other problem, like you've explained. So the other group will be of the congenital. So what is the common causes of the non-genetic ones? So that is where a lot of work is being done, and the non-genetic ones we look at are especially infections that affect the mother as they carry the pregnancy, or we look at things that happen when the child is being born, or the period surrounding the early newborn period. So we look at things like very low birth weight, admission to the neonatal ICU, jaundice or hyperbilirubinemia, a low APGAR score, administration of ototoxic drugs. So those are the 5 common things we look at. Okay. But also during the pregnancy, we look at different infections, and the most identified the culprit is cytomegalovirus, CMV, to be known to cause the non-genetic
Okay.
type of.
Thank you. Okay. And then the acquired causes?
So when we look at the acquired causes, we would look at actually when we take hearing loss in children, the most common cause of hearing loss in children is otitis media with an effusion. That is when you get an infection within the middle ear and it resolves, but some fluid remains in the middle ear cavity. Would say that almost all children will have at least one episode of an OME before their 5th birthday.
Sure.
However, it carries a bimodal peak, and it peaks at around 2 years and 5 years. So children will mostly be affected by this condition because of the nature of their being. There is a tube at the back of the nose that connects the middle ear to the nasopharynx or to the nose. And in this age group, that tube is shorter, wider, and more horizontal. So meaning that the chances for an ascending infection from the nasopharynx to the middle ear is very high compared to the older counterparts. So otitis media with effusion will almost always exclusively affect a child one time before their 5th birthday. So there are some children that are at a higher risk of getting affected. For example, those that live in a crowded house, those that are children in school-going age that are in places that are congested. If there is a smoking guardian in the house where they live, or if they prepare or cook from the house, mainly it's exposure that would give you an upper respiratory tract infection would predispose you to getting an otitis media with an effusion.
Thank you very much, Dr. Masiko. We are having an interesting discussion of hearing difficulties or hearing loss in children as we look forward to commemorating the World Hearing Day that will be celebrated here in Uganda as well in Gulu by the doctors of the ear, nose and the throat. But first, let's have a break. Welcome back from the break, and thank you for watching Bethany TV for Health. I'm your host, Dr. Helen Namsoke, and this is the Pediatric Voice, your show where we discuss the different childhood conditions and how best to help your child grow into a productive Ugandan or citizen. Wherever you are watching from, you can watch Bethany TV Uganda, that is on GoTV channel 841, on free-to-air channel 170, and Star Times channel 8281, as well as on our socials, that is Bethany TV Uganda on X Spaces, Facebook and YouTube. Feel free to share, subscribe, call in your different friends to watch the different shows on the Pediatric Voice as well as Bethany TV at large. Feel free to share the link to the different friends so that they don't miss out on interesting discussions on health. And in our studio today, we are hosting Dr. Masiko Cedric, who's an ENT, that is a doctor for ear, nose and throat at Chibuli Muslim Hospital. And we are discussing hearing loss in children as we are looking forward to commemorating the World Hearing Day that will be celebrated this Sunday, that is the 3rd of March at Gulu. Dr. Cedric, you earlier discussed for us the definition of hearing loss, that is the different aspects that would hinder hearing, right from picking sound to transmitting it and interpreting it to make it meaningful for someone to understand what the other was communicating. And we earlier discussed the different causes of hearing loss and classified as well hearing loss in children. Now, as a parent out there, you know, some children are living with their guardians and some are with the different caretakers. How would I easily get to know that my child could be having difficulties in hearing? It's actually most scary, having learned that most of the time it is as present as birth. How would one know? What are the signs, the tellus signs and symptoms that this child could have difficulties in hearing?
So in managing children, it's always difficult because we have to still categorize into the different age group. One, you have the neonate, then you have the infant, then a toddler, and a much older child who can actually tell you, I'm not hearing. So in an ideal world or in an ideal setting, all your children should leave the hospital at birth when you know that they can hear or they do not hear, or by the very least, like you saw in our documentary, every child should have a hearing screening test by the age of 3 months. So this is something that is being developed and is actively going on with the help of Makerere University and the Ministry of Health, with the ongoing quality-controlled neonatal hearing screening program, which is a multi-center program that is taking place in the regional referrals of Masaka, Kawempe, Mbarara, and Mukono General Hospital.
Okay. So here in Kampala, we all have to go to Kawempe.
Of course, it would be very impossible to get that hearing screening test because of the numbers. However, being a pilot program, there are plans to roll out a nationwide program for us to be able to catch that 1 in 1,000 child at birth.
Okay.
So in the setting that this is not available, how do you
tell? How
do you identify? Well, the number one clue should be given by the parent. And this is where the World Hearing Day comes in. So our role is to create awareness, and in creating awareness, we need to make the parents, the caregivers, the teachers, the guardians, they need to know how this problem presents. So like parents know that my child should sit at the age of 4 to 6 months, should be able to start to crawl at this age. Well, they are not written in stone that when the child doesn't do this or perform this at this age, they've not grown. But it's a milestone guideline.
Yes, we actually have red flags, and we know if by this age the child hasn't done this, there is a problem. So
if you look at gross and fine motor milestones, those are well known by the parents. However, the hearing acquisition or language development milestones are not equally as known. So as we commemorate the World Hearing Day in Gulu, we hope such would be a good platform to know this. So you'll know that your child, at least by the age of 3 months, should be able to startle or to be startled by a loud sound, or to get calmed by a familiar voice. So
if mommy is speaking and daddy are speaking in the house, the baby who has been screaming
should calm down. Or if there is an open door that suddenly bangs itself, the child should startle. When they get to, and remember that hearing goes hand in hand with language and speech development. So at least by this age, the child should have some coos and bubbles.
That is at 2 months.
Yeah. So we are looking at 3 months. So now between 3 months and 6 months, we should have this child.
So in other words, these coos and bubbles the baby is making, they learn them from the parent?
If the child is unable to hear, they'll miss. If, for example, a child with profound hearing loss might not be able to.
So in other words, the parents that breastfeed their children quietly, without any noise, a child may not pick any sound.
Yeah, so would advise them to go for a hearing screening. So by the age of 6 months, the child should not only get startled, but they should be able to localize. For example, if the door hits on the left, they should be able to turn
to the left
and localize. Then as they proceed to get to 9 months, the child is able to develop a monosyllable, one syllable speech.
Da 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 da.
Yeah, like. Then as they proceed to 1 year, they should at least have 2 syllables or be able to make 1 word. Though some children get it later, probably because they have a transient loss.
Or they've not been well stimulated, the parents are too busy. Yes.
So then by the age of 18 months, we expect them to connect 2 words. Then at 24 months, they should at least have a short sentence of maybe 3 words.
Okay.
So that is one way you'd look at identifying all the signs and symptoms of hearing loss in a much younger child that wouldn't tell you that
I can't hear.
Then for the much older children, normally these are identified by the teachers. You'd wonder in a morning class, for example, in primary 7, when they used to do mental work, and the teacher randomly points at someone, Josh, what is 2 times 4? Something that you'd rather think is easy.
And then the child cannot, is just looking.
Is just blank. So a keen caregiver or guardian or teacher would be able to identify, rather than spank the child at that point,
there is a problem.
There is a problem. And these children, normally the body is very special. We try to do some coping strategies. You'll find that some of these children will prefer to sit at the front because they are trying to
pick some sound.
Yeah, to pick some sound much more easily. So also at home, you'll find that some children will want to listen to the TV set or the radio at a higher volume, or you realize that name put to the child.
That's what I was going to say. That is what teachers tell our kids sometimes.
So you need to be keen with this for you to be able to pick it.
Okay, so it is, in other words, it is wrong to just entitle or term a child as a stubborn child. Before you term that to your child, you need to be sure things are okay with the child.
So along with the hearing in general, you'd need to look at because the ear performs other functions. One, you'd need to look at the gross appearance of the ear. The parent will tell you the ear is shaped in a not so normal way, or they'll tell you this ear has a past discharge for so long. The ear also performs the function of controlling balance, but balance in children is much more harder to detect.
They are playful, they are always falling. So how would I know whether the child has balance or not?
It's a slippery slope to talk about.
Yes, very difficult
in children, but it's present with some illnesses sometimes. So in the ideal situation, especially for a child that has admission to the neonatal ICU, a child that had jaundice, hyperbilirubinemia, over Kamuli, or a child that had a low birth weight, prematurity, a child that had a low APGAR score at birth, it would be prudent to have those children screened for hearing loss. And the screening services are available and easy to conduct.
Okay, very interesting. Now, having seen the signs and symptoms, where can, apart from Kawempe, where else can someone go? Because we shall not all flood Kawempe.
So there are several. One, you need to,
can all ENTs do that screening test? Wherever I go, whatever hospital I go to, and I find a doctor or a clinician for ear, nose and throat, can they all perform the test?
The test battery for hearing loss has a number of tests, which are either subjective or objective. So in the much younger children, since they cannot respond, we use the objective tests. These screening tests are carried out by our colleagues, the audiologists, who are the ENT specialists that have gone ahead to look at hearing science in detail. And they are present in both private and
in the government setting.
and public setting.
Okay.
So depending on your choice, you'd walk in to your ENT and they'd recommend the test that your child needs. But the screening tests present at birth are done when the child is either asleep or awake. That's a screening test. So the screening test will either tell you we need to repeat the test later or refer for a higher test.
Okay, that is interesting. So having identified that the child maybe has difficulties in hearing, what can be done?
So when we identify that this child has hearing difficulties, it depends on the age of the child. So ideally, the first, from the much young, for example, those that are born with the hearing loss, is that in the ideal world they should have a diagnosis, or we should know where the problem of the hearing loss is located by the age of 6 months, and at that point some form of amplification or a plan should be put in place, which can be informed depending on the level of hearing, like we talked about earlier. So we'll talk about first the most common cause of hearing loss in these children, which is otitis media with an effusion. Like we say, every child gets it before their 5th birthday.
True.
Luckily enough, it is also self-limiting or resolves on its own as the child grows and the tube elongates. So it resolves on its own, and if it is in a mild form. However, the few unlucky ones get the severe form, that they get a loss of up to 60 dB, which makes it very hard for them to participate in conversational
hearing,
in conversational speech. So this group would you'll visit your ear, nose and throat doctor, and they are depending on the level of hearing. One, you'd have to have a middle ear ventilation tube inserted in your ear, what is commonly known as a grommet, and this would relieve that fluid and you'd get to hear again. And when children get this treatment...
So you mean this scarf fluid can be stuck there for ages?
Yes.
Okay.
So when they get this treatment, the parents on their first review will tell you the child is more interested in the surroundings, because when you do not hear, it has an effect on your psychosocial performance. Children who were previously withdrawn from having interactions with their colleagues, even the teachers will tell you that they are more participative in class. Then a parent told me recently that the child had learnt all the songs, the nursery rhymes wrong because they'd missed some words. Because in our speech, some words have higher frequencies, some have lower frequencies.
True.
And they'll be missing some parts. So they'll sing the rhyme, they'll sing the nursery rhyme totally different.
The different way.
And then they'll come and correct it after the treatment. So that is reversible. It is an acquired illness. It is reversible. And once they get that treated, it goes away for good. Then when we look at the other one that is common in the acquired types is anything that blocks the external auditory canal. That we shouldn't forget is wax impaction. And here I would like to urge the parents to avoid use of Q-tips or earbuds, because the ear is a naturally self-cleaning cavity that the wax falls out on its own. So would advise you not to use the earbuds because they push back the wax into the ear canal, and if you're unlucky, it gets stuck. So they can
even puncture the ear canal, the eardrum.
If you're too overzealous, maybe. However, that would be dealt with the washout, and it would be. But normally that happens with a short transient history, compared to the otitis media with effusion, which is much more common, that presents with a deteriorating hearing loss that is complained about by the caregivers, the parents.
Okay. Yes, any other ways?
So the other ways is when it goes beyond the middle ear and outer ear, then it goes into the inner ear. So one of the ways it is managed is by amplification, and you can only increasing
the volume.
Increasing the volume, and the ear naturally increases the volume with its coupling system. That is the ossicles with the eardrum and the whole system, the coupling system. However, when that is not amplifying enough, for example, a child who has a loss of about 60 dBs, even though the problem is past the middle ear, would benefit from an initial trial for a hearing aid, which is a form of amplification. These two are available in different places. So you need to visit your doctor, then they'll advise you on whether amplification would be a choice. But for you to determine that, you have to first make a diagnosis and determine the level of hearing loss that the child suffers. However, when there are some scenarios when that does not work, then the child would benefit from a cochlear implantation.
So in others, there is a problem with their nerve that transmits sound
with the inner ear.
Okay.
With the inner ear, not the nerve.
Okay. Very interesting. Now, we shall not wait for our children to have hearing defects to be treated, because looks like treating hearing loss is a bit not so simple. It's a bit complicated. So how would someone prevent their child from getting hearing loss?
So the congenital type is prevented by attending your antenatal when you carry your baby. A lot of work has been done, because in managing hearing loss, a multidisciplinary team is important, and prevention, especially for prevention, is key in a low resource setting like the one we operate in. So early identification of whatever risk might
maternal
be, illnesses
and treating them,
but also having a good physiological function during your pregnancy as you carry the baby will go a long way in preventing the likelihood of having a congenital hearing loss. Then when you deliver from a hospital where, because when you look at the things, the key things that are known to be culprits of congenital hearing loss in the perinatal period would look at, like we've already said, a low APGAR score, a low birth weight would be prevented
during antenatal.
Then
jaundice, which can be identified when you deliver.
And treated properly. Then of course, when the child is sickly with sepsis, they'd get some ototoxic drugs, which are also implicated. Then prematurity
can be well handled or dealt with in hospital.
Yeah, so the all and all would be to.
So it goes back to attending antenatal very well and delivering in the presence of a skilled birth attendant.
It's very, very good.
Okay, very interesting. Is stammering a sign of hearing loss?
No.
Okay, very interesting. Are there common myths to hearing loss?
Several.
Like?
So people tend to think that it has no cure, and you'll find that when someone, because like all body parts, when you stop to use one body part, it atrophies and loses function. So you'll find that children who lose their hearing are kept away from the public. And in a sense, that is why they lose even the little speech they've developed. So people do not want, so there is a lot of stigma to hearing loss. They think that it is bad omen. They think that, well, in some cases is familial, but that is not up to the child.
Okay, in just 30 seconds, what is your take-home message to the public?
Let us try as much as possible to prevent hearing loss, and this will do by attending our antenatal care very well, but also giving birth within the presence of a skilled birth attendant. But also we need to be keen and look at these children as they gain their speech, not to make rash conclusion. Omwana tawulira. So you need
Omwana ayina emputu.
Omwana ayina emputu. So before you utter such a statement towards the child, you need to first identify that is this child actually hearing. It could be a physical, yet you miss about 6 months of treatment. And children, because when you look at early childhood development, for you to hit your potential that you would get is very much dependent on your ability to hear, especially in this world where education is for everyone. Even in transactions, you need to be able to hear and comprehend for you to perform to your best ability. So would first, if you suspect any form of, before you crucify someone that tawulira, you'd need to objectively have a hearing assessment.
Very, very interesting discussion we've had this evening about hearing loss in children. And you know what, as you've clearly heard it from the specialist, it is very important to have your child have a hearing screening at least by 3 months, latest by their half-a-year anniversary. So as you plan to cut your half-a-year anniversary cake for your children, you can gift them with a hearing screening test, which can be done by the different facilities, that is either public or private. So whenever can visit an ENT and have your child scheduled for a hearing test. But before going into the facility, you can also be suspicious by your child not developing the necessary milestones, like the cooing or response to the different sounds that come your way can be one of the teller signs whether your child is having hearing difficulties or not. And very importantly, please, whenever you miss your period, it is very important to have a pregnancy test done, and once it is positive, please visit antenatal services wherever they are to the nearest facility, at least on a monthly basis. This will help you identify some of the common infections like German measles, which are notorious at causing hearing defects in when unborn baby, as well as the different conditions like difficult deliveries. Please deliver in the presence of a skilled birth attendant to avoid difficulties and to identify the different conditions in a newborn that may affect their hearing later on, so that they, in case they are present, they can be well addressed, like management of jaundice, treatment of newborn infections with the right medication that are not toxic to your child's ear. That is it we had this week on the Pediatric Voice. Till we meet next time for more interesting discussions about childhood health. I've been your host, Dr. Helen Amsoke, and today I had Dr. Cedric. Thank you.